Hello, everyone. Again, so we're in the final part of the renal physiology. Basically, we're going to talk about the electrolytes. Um, how does the kidney able to regulate the electrolytes? Okay, so there's a lot of electrolytes, but we're just going to focus mainly on potassium, calcium, phosphate. Sodium, actually, we already tackled it in the beginning, okay, in terms of regulate, because remember, sodium handling will reflect your extracellular fluid, okay? So, so let's briefly talk about the sodium renal handling or the sodium balance somehow, no? So I wanted to make a joke about sodium, but nah. Anyway, so just to recall, remember that majority of your sodium are actually reabsorbed. 99% of them are reabsorbed, and only 1 or less than 1% are actually secreted or excreted. No, and major site of sodium reabsorption always happens to your proximal tubule. Okay, well, proximal convoluted tubule, and some of them are reabsorbed in proximal straight tubule, but basically overall, 67% are reabsorbed in proximal tubule. No, and kidney is the major site of excretion of your sodium. So if our, again, I told you, if our body does not need of fluid, we have excess fluid, the kidneys will excrete sodium, okay, so that water will follow to decrease the blood volume and then eventually decrease the blood pressure. Okay, remember that in the proximal tubule, thick ascending limb as well as in early distal tubule, okay, the sodium are actually reabsorbed. We call it obligative reabsorption, meaning it will be reabsorbed. There is a constant reabsorption of sodium, may be affected by your glomerulotubular balance or by your starting forces, but overall, it has to be reabsorbed. Okay, so yun. But if you compare it with the late distal tubule and then the rest of the duct, collecting tubules, this is the area where we will adjust our reabsorption of sodium. Like if we need sodium so that we can increase our blood volume, then these two areas will be enhanced or enhancing sodium reabsorption. But if we don't want to reabsorb sodium, then these two areas, there will be lower reabsorption of sodium. Okay? So a positive, yun nga, depends on the sodium, depends on the ECF volume, di ba? Positive sodium balance will lead to a more volume expansion. Of negative sodium balance will lead to a volume contraction. So like I've told you earlier, in let's say there's a normal blood volume, okay, euvolemia, there will always be a sodium reabsorption in your proximal tubule, in the loop of Henle, because of the GFR, the glomerulotubular balance, the tubuloglomerular feedback, as well as the transporters that we are reabsorbing are secondary active, like your early DC, like your sodium amino acid, sodium glucose importer, your NKCC channels, your sodium chloride importer, while on the other aspect, your distal tubule, the late distal tubule and collecting duct, dependent on the aldosterone, okay, which is synthesized in the adrenals, which is activated by your angiotensinogen, or basically activated by the renin angiotensin aldosterone system. Okay. At the same time, natriuretic peptides will inhibit sodium reabsorption at those areas, so because they inhibit aldosterone. So the ENaC, the epithelial sodium channel, will not be activated in those areas. So, sabi ko nga, constant dito sa first two, adjusted dun sa distal tubule and collecting duct. A little bit similar to your water, di ba? Water reabsorption is somehow constant in the proximal tubule and the descending limb. But in the late DCT and your collecting duct, dependent on the ADH. Of course, if there's a changes in volume, like volume contraction and volume expansion, there will also be corresponding changes, like RAAS and sympathetic will be activated in the volume contraction. There will be less GFR somehow, enhanced reabsorption of sodium. We tackled that already in the last video, okay? Volume expansion, on the other hand, will be the opposite. The ANP will be activated while inhibiting your RAAS, sympathetic, etc. That's why Basically, handling of sodium is basically handling your body volume. Okay, that's how the kidney regulates it. I want to increase my body volume, I will regulate sodium. I want to decrease my body volume, I have to regulate sodium. Because changes in sodium will change the osmolarity, then eventually will cause volume changes also. Okay, that's why let's talk about potassium. Okay, how about potassium? How does the kidney able to regulate our potassium? Take note, for sodium, we have the normal volume for sodium, normal value for sodium is around 135 to 145. So there's a way for that. There's a 10 millimoles of um, allowable, no? For potassium, it's a different thing. Remember, there's a very small amount of potassium in the extracellular fluid compartment in the plasma. No, there's very minimal. That's why the adjustment or the how does the kidney able to adjust your potassium is very intricate, very mabusisi. Okay, they're really as much as possible mabusisi. Why? I'll tell you later. So again, potassium is the most abundant intracellular cation. The function of potassium is very important because, as you can see in the slide, no, for cell volume somehow, for pH, there's involvement of potassium with the pH, for enzyme, for resting membrane potential. Potassium is the conductance of potassium channels is very important for the RMP, diba? Affecting your potassium will affect your RMP by maybe increasing or decreasing it. Okay, it affects the cardiac and neuromuscular activity because they affect the RMP. If you remember, okay, I'm just giving recalls information. And that's why potassium is very important. Okay. Overall, potassium, majority of your potassium, again, is located intracellularly, 98%. Only 2% are extracellularly, no? So you can see that there's around 60 only, no? So extra, majority are intra. What happened to the rest? No, pag marami kang kinain potassium, let's say, ang dami mo kinain banana, okay, or tomato, those are rich in potassium. What happened to those excess ingested potassium? You excrete them, whether to the feces or to the kidneys. Okay, so this channel, the sodium potassium ATPase pump, maintains the intracellular potassium high. So the normal value for potassium is around 3.5 to 5.0. Some books will probably tell 3.8, 5.2, pero nandyan yung standard. Now, earlier sabi ko si sodium, hindi masyadong very strict si kidney kasi 135 to 145. You have 10 millimoles of milli-equivalents na difference between upper and lower limit. Potassium is just very 3.5 to 5.0. That's 1.5 difference. Okay? So, in short, a little bit increase, okay, will cause problem. A little bit decrease will cause problem already. So, very narrowed yung normal value. That's why si kidney very sensitive siya, very possessive, making sure that the normal value of potassium is within the normal limits. So there are two mechanisms of making sure that the potassium is within, okay, the extracellular potassium is within that normal limits, 3.5 to 5.0. One is regulating the potassium in the ECF, meaning there are three hormones important, making sure that the potassium in the ECF is actually low, is actually within 3.5 to 5.0. On the other hand, the kidneys can adjust. No, the kidneys can, there's a lot of potassium in the ECF. Maybe I can just, excrete them all because we don't need them all. Okay, we can excrete them kasi hindi naman natin kailangan. So basically, two areas. Either go inside the cell or you go out via the kidney. So this picture from the burn shows us that. So first, let's talk about what are the three hormones that make sure that the potassium, as much as possible, is within 3.5 to 5.0. Okay, there are three important hormones, and those are your insulin, epinephrine, and aldosterone. Okay, so you might wonder, how do they make sure that the potassium is within the normal or constant? So epinephrine. So for epinephrine, it decreases your potassium by allowing the potassium to go inside the cell. Paano, no? By beta receptor. So if you see this statement here, epinephrine released by adrenal medulla. So epinephrine can bind to alpha or beta adrenergic receptors, but somehow they said that epinephrine has more affinity with beta. Epinephrine has more affinity to beta somehow. Okay, beta receptor will promote potassium uptake inside the cell. So epinephrine will allow potassium to go inside the cell so that potassium will not accumulate in the ECF. Okay? Okay. How about insulin? No? For insulin, on the other hand, the same thing, same as your epinephrine, decreases potassium by stimulating the uptake of potassium into the cell, especially after meal. Of course, let's say kumain ka ng maraming potassium, the ECF will probably expand or increase with potassium. So insulin will be released. Insulin will cause glucose uptake. Okay, you'll know that in endocrine, but at the same time, insulin will also cause potassium uptake, making sure there's no excess potassium in the plasma. At the same time, potassium can be excreted via the kidney also. Okay, and that's why patients who have diabetes, no, type 2 diabetes or type 2 diabetes somehow, no, they don't have insulin, and then that's why there's the one of their complications is that they can be at risk of having hyperkalemia or high potassium level. Again, anything excess or low, okay, is a dangerous path for us. Okay, yeah. And that's why one of the treatment, if patient have hyperkalemia, okay, sometimes, okay, you will know, some nurse here, some of you are probably nurse, have encountered, no, they also give insulin just to decrease the potassium level. Let's say a patient came to you, okay, in the ER, patient is around, the potassium level is around 6.57, actually sometimes 7.0. So 5 yung upper limit, 7, okay, 7 sometimes can cause already mortality. Pwede na mamatay yung pasyente doon. But 2 milli-equivalence difference lang pwede na mag-cause ng a lot of complication. Unlike sodium, 145, maging 150 yan, 5 difference. Okay ka pa eh, medyo stable pa, pwede ka pang, kaya pang gamutin, kaya pang compensate ng katawan. For potassium, it's a different scenario. Okay? So very and last, aldosterone. Oh, aldosterone again, no? Aldosterone. So from the adrenal medulla, the adrenal cortex. So aldosterone not only reabsorbs sodium, but have to excrete potassium. Okay, how can I excrete potassium? How can I decrease potassium? Aldosterone will promote urinary potassium excretion. Okay, so later you'll find out, no, aldosterone will reabsorb sodium, pero may kapalit yun, no? May kapalit yun. Kailangan niya tanggalin si potassium. That's why patients who have elevated of aldosterone levels will have hypokalemia. Okay? Hypokalemia. So those are the 3 hormones that will keep your plasma potassium within the normal level. Okay? So, yeah. So now we're done with the 3 hormones that make sure potassium is within the normal. But there are factors that derange your potassium level. Okay, they make increase or decrease of your potassium. Okay, that's why you can see here factors that affect your plasma potassium, but not part of the regulation. They are kumbaga found in an abnormal situation. Acid-base disturbances. If you have acidosis or alkalosis, it will affect your potassium. Okay, whether increase or decrease. Plasma osmolality, again, when you have high levels of plasma osmolality, it will affect your potassium level. Cell lysis, remember, most of your potassium are found inside the cell. So if the cell destroyed, more potassium will go out. Technically, it will increase your potassium level. And exercise, okay, exercise. So we'll tackle them one by one. Let's talk about acid base. So you have here acidosis. No? Sabi dito, acidosis tends to shift potassium out of the cell in exchange for H. So that will lead to high potassium level. What do I mean by that? Okay, in acidosis, what is more elevated? What will happen? Sorry, what will happen to your hydrogen ion? Is it high or low? Okay, it's actually high, no? So it's actually high because H ion is an acid, so there's more H ion in the plasma. The compensation, well, what it will do is that H ion should go inside the cell so that to decrease the H ion. Pero hindi pwede yun. Dapat may kapalit. Ang kapalit si potassium. So, H ion goes inside, potassium goes out. So, there will be abundant of potassium outside the cell. So, there will be high plasma potassium level. Alkalosis is the opposite thing. Alkalosis, there's no hydrogen ion outside. So, you need hydrogen goes out, potassium goes in, hypokalemia will happen. Okay, just to maintain neutrality, naglabas ka ng potassium, naglabas ka ng positive, kailangan may kapalit na positive. So, ganun siya. They also know that acid H ion also inhibits this sodium potassium ATPase. Thus, more potassium remain outside the cell. Thus, that's why acidosis have high plasma potassium. To understand, to a mnemonic for this, I'm not sure if this is effective. I always, someone told me, no, during my, when I studied for board exam, alkalosis, low, L-O, losis. So basically, it refers to hypokalemia, alkalosis, low potassium. So yun na lang. So just on the picture, this one represents a acidosis, so they will just exchange. This one represents alkalosis, so they will just exchange. Okay? So how about plasma osmolality? Ito na naman si plasma osmolality. An increase in plasma osmolality will enhance release of potassium. So high plasma osmolality will lead hyperkalemia. How? So because of the volume changes inside the cell, no? Inside the cell, So if there's high plasma osmolality, let's remember what we have discussed in the changes of volume and osmolality between ICF and ECF. If there is high osmolality in the ECF, will there be water movement? Yes. Water will move where? Going out or going inside? Water will move from low concentration to higher concentration. So water will move from inside the cell going outside the cell kasi higher tonicity sa outside. So basically, what happens to the volume inside the cell, it decreases. So high plasma osmolality, water will leave the cell from ICF to the ECF. So as water loss, okay, as more water goes out of the cell shrinks, diba? If the cell shrinks, less volume, you concentrate the potassium, like this picture. So as the cell becomes smaller, the potassium concentrates. As the potassium concentrates, okay, there's a driving force. So parang potassium goes out kasi nga nag-concentrate siya. So parang passive diffusion, no? From a higher concentration to a lower concentration. Potassium goes out, flow gradient. That's why there will be hyperkalemia effect. That's why in patient with diabetes, aside from you don't have insulin, patient with diabetes have high glucose level, high plasma osmolality, thus it will exaggerate the high potassium level. Okay? How about cell lysis? Okay, cell lysis. Again, in cell lysis, there you just destroy the cell. And that's why patient with hemolysis, okay, red cell destruction, what else? Severe trauma, like rhabdomyolysis, muscle cell destruction, like after hazing, patient have most of the muscle was destroyed. Not only hemoglobin was released or myoglobin, but you also release potassium. Tumor lysis syndrome also. What is tumor lysis syndrome? This is a situation where patient underwent chemotherapy. Sad to say, too much, parang masyadong naparaming tumor ang namatay. So remember, these tumors are also cells, and inside their cells, there's a lot of potassium. And that's why what we try to find out, okay, in patient undergoing chemotherapy, we also check their potassium level because too much cell destruction in chemotherapy can cause hyperkalemia and can cause problem. And that's why hindi rin pwedeng too much or rapid destruction of your tumor. Okay? Kaya hindi rin pwedeng sobrang taas ng dosage ng chemotherapy that can cause tumor lysis syndrome. It will cause harmful effect. Okay? So, in short, cell destruction release potassium inside the cell to the extracellular, leading to hyperkalemia. And exercise. When we do exercise, no, our muscles are contracted. You also release those potassium. And that's why hyperkalemia. But whenever we do exercise, epinephrine also release. And epinephrine will control this potassium, no? So when we do exercise, potassium goes up, but epinephrine also goes up. Epinephrine will counteract, decrease it by, but epinephrine will cause uptake, okay, uptake of your potassium. And that's why, yun, that's why when we do exercise, okay, hindi naman tumataas yung potassium level agad talaga natin. It increases temporarily, but epinephrine will decrease back to normal. Okay? But too much exercise probably, no, yung mga high intensity training, maybe, okay, magkaka-problem na tayo. Okay. So in summary, how the influence of your plasma K, okay, is these three factors shift the potassium inside the cell. Basically, these three factors decreases the potassium level. Opposite. Okay, tignan mo yung opposite niya. So epinephrine, ano opposite niya? Blocker. Okay, like a beta blocker, epinephrine blocker or beta receptor blocker. Aldosterone, ano opposite niya? Aldosterone deficiency. Insulin, anong opposite niya? Insulin deficiency like type 2. All those three will be causing increased plasma K. Okay, what else? Alkalosis and acidosis, di ba? Alkalosis, low potassium. Acidosis, hyperkalemia. Okay, and then exercise, increase exercise, and your cell lysis and increased plasma osmolality. Okay, so we're done with plasma K. But the other mechanism of regulating your plasma potassium is through kidneys. And this is now more an important issue for us. How does the kidney able to regulate potassium? So, for reabsorption, we know there's a potassium reabsorption. Like this picture shows us that there is a reabsorption in the proximal tubule as well as thick ascending limb, no? And it's a constant. Like your sodium and water, there's a constant reabsorption of potassium in these two segments. It can be affected by tubulo-glomerular or glomerulo-tubular balance as well as the stalling forces. Doon lang siya na-affect, doon lang nagkakaroon ng decreased reabsorption via stalling forces or glomerulo-tubular balance. But overall, percentage-wise, there's a constant reabsorption. Okay, ibang usapan sa distal tubule and collecting duct. In distal tubule and cortical collecting duct or medullary collecting duct, the reabsorption and secretion varies. Okay, so we will encounter principal cells again and intercalated cells that we discussed in the renal physiology 1. Okay, you can see 3 to 9% lang siya, no? So if we ingest a lot of potassium, if we don't need potassium, we have high levels of potassium, reabsorption in these two areas will be decreased. Rather, there will be secretion. Ulitin ko, if we have too much potassium, we rather secrete potassium because we don't need potassium. We want within normal level of potassium. But if we are low potassium level inside the body, these two segments, okay, your distal and collecting duct will enhance reabsorption of it. Okay? So, enhance during potassium depletion. So, meaning, whenever we don't have potassium, we are, let's say, losing potassium in our diet or in our body system, there will be reabsorption in distal tubule and your collecting duct. Okay? And collecting duct. The cell responsible for reabsorption is probably your intercalated cell, your alpha or type A intercalated cell. Okay? Later, we'll talk about that. While in secretion, okay, paano pag secretion? Remember, in secretion, constant ang reabsorption. Now, you can see there's a changes now. Secretion, the arrow now goes to your tubule. So, there will be secretions, okay, in distal tubule and collecting duct. Secretions may reach 10 to 50%, 5 to 30%. Overall, there will be an excretion of your potassium around 15 to 20 to 80%. Okay, 15 to 80%, depending on situation. Situation like diet. Okay, hormones like maybe you have excess aldosterone, okay, or other factors, acidosis, alkalosis, okay, those things that we have discussed in the plasma K regulate, plasma potassium regulation. Okay, overall the excretion varies, no, 15 to 80, depende. Too much, kunyari, if your potassium level is, let's say, nasa 7, dangerous yun. As long as your kidney is intact, okay, you will maximize it. You will excrete it like 80%. And that's why, okay, that's why a patient with kidney problem, okay, patient with kidney problem, example, the tubule, the distal tubule and collecting duct are destroyed or nasira. patient will have problem in secreting potassium. So patient will have difficulty secreting potassium. That's why patient with kidney problem are prone to have high level of potassium. I'll repeat, patient who have kidney problems have problems also regulating their potassium that will lead to hyperkalemia because they could not secrete them properly because it's malfunction. Okay? So let's go cellular. What is the mechanism for potassium secretion? So this cell is your, I believe this is your principal cells, okay? Because principal cells secrete potassium. Type A intercalated cell reabsorb potassium. So yeah, beta intercalated cell have minor role. Some books will tell you beta intercalated cell also secrete potassium, but minor role, hindi ko na yan tatanungin. More of si principal cell yung mas importante sa akin. So what is the step-by-step mechanism for potassium to be secreted properly? So first, the activation of this channel, the sodium potassium ATPase should be activated. Okay, so once this is activated, more potassium will go inside the cell, more sodium will be reabsorbed. What else? Because of that, there will be accumulation of potassium inside the cell. Ang dami-daming potassium because of this because of the sodium potassium ATPase pump. This will cause the drive or increase the permeability of potassium. Because of the increased potassium level inside the cell, you establish the electrochemical gradient, you cause the permeability of potassium going out through this potassium channel. This potassium channel, we call it BK or ROMK. BK stands for big potassium, hindi Burger King, but big potassium channel. ROMK stands for renal outer nakalagay dyan, renal outer medullary potassium channel. Okay? So these are the three factors that control the rate of potassium secretion. Any one of them is affected can lead to a problem with potassium secretion. So if you affect your sodium potassium ATPase pump, that can lead to a hyperkalemia. I remember, I think there's one medication for those who are pharma graduate, a medication that inhibits this channel, this sodium potassium ATPase pump. Eventually, because they inhibit the channel, patient have one of the side effect of that medication is hyperkalemia. Okay, I think that's digoxin, no? I think, I'm not sure with that. Pero yun, okay, that's why, diba, no? If you have problem with electrochemical gradient, then there will be no permeability. If you have problem with the potassium channel, then you have problem with that. Okay, why the movement to apical, not basolateral? Because again, the gradient of potassium favors the downhill movement than basolateral. Okay, apical channel is more permeable than basolateral. Doc, what is the difference between BK and ROMK? This is the difference. Okay, in patient with low potassium, patient mababa potassium sa katawan, of course both channels will be closed kasi we don't want to secrete potassium kasi mababa na nga yung potassium, we want to reabsorb potassium. So type A intercalated cell will be activated. Now, let's say our potassium is within normal lang naman. So we just have normal excretion of potassium. The ROMK is open. Okay, ROMK is open. But the BK is closed. So, ewan ko bakit basta close siya. But when there is a high potassium in the body, we need to enhance high potassium excretion, then the BK will open. So, Burger King open. I'm just thinking, no, pag marami kang kinain, maraming potassium sa mga products ng Burger King, that's my mnemonic. Okay, I'm not sure if that's really true. You can ask a nutritionist, but that's my mnemonic, no? Sa Burger King, maraming potassium na pagkain. Kaya pag maraming potassium, maraming kang excrete, Burger King should be open. I don't know. That's just my, hopefully it will be helpful for you. Now, for reabsorption, I've told you, it happens in the type A or alpha intercalated cell. And it only enhances whenever there's a low potassium diet, as you can see. And how do you reabsorb potassium? Hydrogen, potassium, ATPase pump. The same pump, okay, as your in the parietal cells. So this pump will cause hydrogen to go out. Hindi pwedeng walang kapalit. Dapat may kapalit na potassium or may kapalit na positive na cation. and that is your potassium. And then eventually, potassium will be reabsorbed here. Okay? That's why in type A, di ba, type A intercalated sa A, they secrete hydrogen, they secrete acid. In type B, they secrete bicarbonate. Hydrogen is reabsorbed, kapalit si bicarbonate. You'll know that in the acid base by Dr. Jacinto. Okay? So, now, how do we regulate the potassium secretion? So, kanina, plasma potassium yun ha. We're talking about how do we regulate plasma potassium in the ECF. Diba? The three, insulin, epinephrine, and aldosterone. How about in the kidneys? Who dictates more potassium secretion or less potassium secretion? Okay, so for regulation of your potassium excretion is mainly by the alteration of potassium secretion by principal cells. Okay, principal cells. So there are two most important. Okay, plasma K and aldosterone. Okay, those are the two most important regulation for renal potassium secretion. The others are not so, but also we'll talk about that briefly. So whenever you have high potassium level, like hyperkalemia, maybe from the diet or destruction of the cell, okay, remember, as long as the kidney is intact, what we're talking about here is kidney is intact so that we can excrete potassium. So whenever you have high potassium level, there will be more reuptake of potassium inside the cell through this channel, the sodium potassium ATPase. Thus, it will lead to increased potassium inside the cell. Thus, there will be enhanced cellular secretion of pure potassium because of increasing the driving force. We talked about this in the previous two slides, I believe, no? On top of that, there will be more increased permeability of the potassium in the apical surface of the intestinal, in the tubular cells. There will be hyperkalemia will also enhance aldosterone secretion. Hyperkalemia will enhance aldosterone secretion. And aldosterone is one of the factors that enhance potassium secretion in your kidneys. And then also whenever you have hyperkalemia, you also increase flow rate, okay, because of an expansion of your ECF. We'll talk about this last box later on, okay? Overall, all these things will increase potassium secretion in the distal late DCT and collecting duct, thus decreasing your plasma K back to normal. Okay? So that's it. Hyperkalemia, enhanced potassium secretion, brings your potassium level back to normal. Okay. How about aldosterone? Okay, so earlier sabi ko, aldosterone will enhance sodium reabsorption but enhance also potassium secretion. Okay, dalawang action niya. Reabsorption of sodium, potassium secretion. How? So the stimulus for aldosterone is high potassium and the angiotensin aldosterone system. Okay? So what's the mechanism? So first, it will enhance the sodium potassium ATPase. Laging ganyan, no? Para more potassium inside the cell. And then the aldosterone will enhance the expression of this channel for sodium reabsorption, no? For sodium reabsorption. So more sodium will be reabsorbed because there's more ENaC channels, okay? And then it will enhance this SGK, your serum glucocorticoid stimulated kinase. What does this SGK do? SGK will enhance ENaC and enhance potassium channel. Okay, so yun. Then eventually, the aldosterone will also enhance this CAP or channel activating protease. Okay, or prostatin. In other books, prostatin ang tawag sa kanya. But anyway, CAP, which enhance your ENaC. And that's why aldosterone enhance sodium reabsorption, enhance potassium secretion, and then eventually increase the permeability of potassium. By the way, if aldosterone enhance potassium secretion, take note angiotensin 2 inhibits potassium secretion. Aldosterone enhance potassium secretion, angiotensin 2 inhibits potassium secretion. Okay. So, those two are the most important regulator for potassium, renal handling of your potassium. How about ADH? You can see here, ADH enhance potassium secretion, but not overall excretion. Huh? In short, ADH will enhance secretion. Pero there is something factor that will increase reabsorption of potassium. That's why overall there will be negligible excretion of your potassium. Okay. Remember, secretion and excretion is not the same thing. Secretion is to secrete. Excretion is where you already now find it in the ureter, in the bladder, in the toilet bowl, no? So that's why ADH enhance secretion, but it doesn't mean that I will enhance excretion of your potassium. Okay? Unlike hyperkalemia and aldosterone. So how do I able to enhance potassium secretion? By sodium reuptake. Okay? Ganun lang, kapalitan lang naman sila eh. Sodium reuptake, potassium secretion. Ganun lang yun. But why is it that excretion is not affected? Because there will be decrease in the flow of tubular fluid due to reabsorption of water. Okay, the function of ADH is to reabsorb water. So if I reabsorb water, will there be enough fluid in the tubules? Probably not. Medyo hyper-concentrated na yung nasa tubular lumen mo kasi nag-reabsorb ka ng water. So, in short, there will be less tubular fluid that will result to less urine output. So, this decrease in tubular fluid will cause something, okay, which is on the next slide. So, you know that whenever there's a whenever there's a high flow rate, there will be high potassium secretion. Whenever there's a low flow rate or low tubular fluid, there will be low potassium secretion. So in short, kanina, ADH enhanced potassium secretion, but ADH will also cause low tubular fluid flow rate kasi nag-reabsorb ka ng water. So a decrease in tubular fluid or tubular flow rate will decrease potassium secretion. So overall, they just nullify each other. That's why excretion-wise, hindi masyadong affected. Okay? Excretion-wise, balance. Okay? Why is it like that? Bakit? Again, our normal value for potassium is 3.5 to 5.0. So as much as possible, okay, ayaw natin na exaggerated excretion. Kasi kung nagsabay-sabay ang hyperkalemia, aldosterone at ADH na walang kuya ang ADH it will also enhance potassium excretion. From 6.0 na potassium, probably after one day biglang baka maging 2.0 siya. So that is dangerous also. So with this mechanism, it just tells us that kidneys are very, very meticulous in trying to make sure potassium should be within the normal value of 3.5 to 5.0. Okay? So, tubular flow rate will enhance potassium secretion. High flow rate, high potassium secretion. Low flow rate, low potassium secretion. Paano nangyari yon? So, whenever there's enhanced volume or volume expansion, ECF volume increases, GFR increases, tubular flow rate increases. So there will be less sodium reabsorption, less water reabsorption. Remember, we talked about that earlier. So less water, less sodium reabsorption, less ADH. So less ADH, no ADH, potassium secretion decreases. But high flow rate, increased potassium secretion. So again, they nullify each other, balance lang. So more potassium, more sodium. By the way, yeah, like you can see here, more sodium in the lumen, okay, it will cause the high flow rate will bend the cilia. When you bend the cilia, you activate these channels. So sodium goes inside, calcium goes inside, and calcium will enhance this potassium channel so that it will enhance potassium secretion. Okay? Take note, yung sodium reabsorption dito, hindi to dahil kay aldosterone. It's just because of the increased flow rate stimulates the sodium entry, pero not enough, okay? Not enough to increase sodium level, okay? Siguro ang function lang ito, making sure lang na hindi sobra-sobra kang nag-excrete ng sodium. Okay? So, overall, what happened there is that high flow rate, high potassium secretion. But again, high flow rate, high potassium secretion, no ADH. If you don't have ADH, no potassium secretion. So they nullify each other lang. Okay? Then low flow rate, low potassium secretion. Okay? So take note. Okay? ECF volume, di ba? ECF volume expansion will enhance sodium excretion, water excretion, and potassium secretion also. No? Potassium secretion. So in short, wherever sodium goes, water will follow, and the rest of the electrolytes will follow. Mamaya mapapansin yan when we talk about calcium, phosphorus, and your magnesium. Okay, so again, whenever there's a volume expansion like increased sodium intake, so there's a decreased aldosterone because RAAS is inhibited, GFR will be activated, less sodium reabsorption will happen somehow because of the tubuloglomerular feedback, okay, or tubuloglomerular feedback and glomerular-tubular balance somehow, no? So there will be increased tubular flow rate, okay, and then increased tubular flow rate will cause potassium secretion. Low aldosterone will decrease potassium secretion. So overall, the potassium secretion is usually a little bit unchanged. And again, why is it that as much as possible, I'm talking about in normal individual, the potassium excretion should be always as much as possible minimal. Because again, we don't want excessive potassium secretion or excretion that can lead to abnormal level of potassium. Okay? So, yun siya. Okay? So, this tells us the relationship between ADH and tubular flow rate, no? One enhance, one inhibits overall negligible effect. One, ayan, as you can see here, no? So, overall, there's a constant potassium balance as much as possible, okay? As much as possible. Now, how about acidosis again and alkalosis? So, acidosis will enhance potassium secretion. Okay? Will enhance potassium secretion. Okay? Yun na yun. Sa enhance potassium, decrease potassium secretion. Okay? What happened here is that in acidosis, I want to excrete hydrogen ion in the kidney. Kasi acidotic ako eh. So, kailangan matanggal ko si hydrogen. So, I have to remove hydrogen in exchange for potassium. Remember type A intercalated cells. Okay? So because of that, potassium is reabsorbed or less secreted. That's why potassium accumulates. That's why acidosis, hyperkalemia. In alkalosis, baliktad naman. Okay. Now I have to reabsorb potassium. Sinong kapalit? Si hydrogen. Now I have to reabsorb hydrogen. Sinong kapalit? Si potassium. So potassium is being secreted and excreted, hydrogen is being reabsorbed. So alkalosis can result to a hypokalemia or low potassium level. Okay? So kung masyadong naming words doon, ang naming words, ito na yung summary. A high potassium level will lead to enhanced tubular secretion and then more found in the kidney. Okay. Aldosterone is the same thing. High aldosterone enhance potassium secretion. ADH also, high ADH will increase potassium secretion, but overall the excretion is not really that affected. Okay. While acidosis is the unique. High H level will exchange with potassium. That's why high H level will decrease potassium secretion. Thus, overall, excretion is negligible, decreased. That's why acidosis leads to hyperkalemia. Alkalosis is the opposite naman. Tubular flow rate, high secretion. Take note, excretion will also be enhanced, especially too much tubular flow rate, okay? And the glucocorticoids, don't mind that, okay? So, in summary, we've discussed the plasma potassium and the potassium handling in the kidney. Okay, and then the regulation in the plasma K, the 3, and the regulation of renal K secretion, which is this followed. So, give me the 3 physiologic factors that keep the plasma K constant. What are the nephron sites that do potassium secretion occurs? So, there are 2. Diba? May constant reabsorption. Then there are 2 areas where there's a variable reabsorption or secretion. What are the 3 cellular mechanism for potassium secretion? And give at least 3 factors that enhance potassium secretion and their rationale. Okay? So with that, I hope you try to answer this concept checkpoint, and then you will probably do well in your exam. So I guess that's the end of our video for sodium and potassium.